we have this meeting twice a month, and twice a month we have technical, issues going on. So thank you all for joining our CMDA monthly meeting today. We're so happy to have you here. And happy that you're able to spend some time here, even though we just came off of a long holiday weekend. So today, I'm just going to make some announcements before we get started. Our journal club is on Thursday, so be sure to come back to this Zoom link on Thursday at 12:30, and Dr. Shepard will be leading journal club this week. One of the big hot topics right now is the physician fee schedule that has been proposed by CMS. And several of our members here at CMDA have expressed concerns about various parts of it. Now, I want to encourage all of you to get knowledgeable about it and write to CMS about what you think about some of these aspects. We've tried to make it easy for you. PALTmed and our CMDA Public Policy Committee have sent out this email last Saturday, and I'll send it out again this week with some templated comments that you can start with. Some of the issues that have come up that we are all concerned about or want to make sure that CMS hears from us about are the reduction in the physician fee payment rates and the practice expense rate that they're proposing to cut, which would reduce payments for nursing home services. There's also a chronic condition management code that is not applied to both nursing homes and assisted livings. Maybe they should be for both. And there's also a proposal to change the way that skin substitutes are paid for. And if that goes through, it could actually save us a lot of money and perhaps reduce the misuse of that treatment. So please take a look at that physician fee schedule. I'll go ahead and put the PALTmed link into the chat box. You can just do it during this meeting if you want to. CMS is allowing community members to make comments until September 12th. You can also check your CMDA emails. And final announcement from me today is that the CMDA name is changing this year. We are officially moving forward, going to be called PALTmed-Colorado. I think for this year, we don't want to make a drastic change. We're just going to go by both names for now. So you'll hear us refer to this organization as both PALTmed Colorado and CMDA. But same organization, same great members as always, and hopefully the same great content. We thank you all for your support. So let's go ahead and start with our updates from our partners. And thank you, Jenny Albertson and Chad Fear, for both being here. Jenny, would you like to go first? I put you first because you were second last time. So
Sure, absolutely. I'll go ahead and share some slides here with you all. I just have a couple of things this morning. I guess it's afternoon already, isn't it? Let's go ahead and get into it. So I can send these out to you, Sing, in case anyone might want these for reference. First of all, since I've actually received calls from medical directors in a couple of these instances, I want to make sure you are all apprised of the fact that we should be expecting some monitor visits. They may sound like they are directly from the Department of Justice, which makes them sound a little scary, and that thus phone calls to me. What happened, and I think we've gone over this a bit in the past, is several years ago, the Department of Justice filed a lawsuit against the state of Colorado, alleging that we were inappropriately institutionalizing people instead of getting them through the nursing home, skilled nursing stay back into their home environments. And so because of that allegation, the state had to go through multiple discussions and negotiations with the DOJ. It took them 7 years to reach a settlement. When they did finally reach a settlement, we saw things such as the transition program roll out through HCPF. And because of what came to be the general agreement through the settlement, we now are facing a scripted transition process, which will require HCPF to transition 2,000 individuals from nursing home care into community settings utilizing these new transition services. In at least 950 cases, they have to go through the actual transition coordination through the state. And they have until 2028, October, to reach that goal of 2,000 people. To that end, there is a plan. There are things we have to participate with them. And one of those things is that they send out a court monitor to ensure that we are cooperating and they are providing a level of communication about the services that are available to our residents to get them back into the community should they perhaps be eligible. So this is just a matter of going into a building and saying, I need your list of Medicaid residents. And then we say yes, because we see that you are the court monitor. And then they get to meet with residents and ask them about their stay. In some cases, this has caused a degree of upset in the resident population, as I'm sure you can imagine, people that perseverate on leaving. This is causing them to perseverate again when they perhaps were in a place of temporary peace. So I have witnessed this being kind of a difficult thing in a couple of cases, but it is mandated for them to monitor that this is happening appropriately in our communities. So you will also see in-reach visits where transition coordination services from the Medicaid office come in and sit down with families and residents in a group setting and do a broad introduction to the whole concept. That has to happen at least once a year, if not every 6 months. And so all of this is part of the same Department of Justice settlement, and we do need to cooperate with it, and it is HIPAA protected. So there's your reference on that. Many have asked about the special legislative session that was just held, and the governor had some very specific agenda items going into that session. We were worried that we might be one of those, and turns out nursing homes were protected. So here's the outcome from the special legislative session. Our 1.5% increase to the nursing home provider rates will not be reduced this year. The 1.6% increase for all other types of Medicaid services, including HCBS, is being eliminated. So that was cut from the budget. That change is going to be noticed in September and October. So I don't know how that will concuss our environment, but I imagine we will feel some reverberations there in terms of home care-based services and what people will be provided in the home. The SNF minimum wage enhancement program is a sunset we already anticipated. That was basically getting everybody to a base wage of $15 an hour. Wasn't an issue in metro areas because we exceeded that by far, but in the rural areas, some of them had to come up to speed on that, and the state helped them afford that in the short run. Now it's sunset, so the state help is not happening moving forward. It's just incorporated into our operating. And then there are some reductions being made to CDPHE in the public health function. I don't know how that's going to look yet, but we've been in very consistent conversation with the IP team, particularly since that particularly supports us. And I'll let you know if things come down in that area. They also did cut some housing funds, $100 million, which again, we will see some repercussions from that. Higher education is being cut $50 million. The Medicaid reduction is about 70 million, a little over that from the home care-based services and so forth. This was a win for us as a profession, but we do need to brace ourselves for next year because the next legislative session starts in January. And you can bet that us being a very large budget item, we will certainly be under discussion for the new budget year. This is good news. I seldom get to say that there's good news in survey changes. CMS has sunset also the infection control surveys that were happening during COVID that were kind of an anomaly actually in our world. We saw a massive increase in deficiency citations, not just for infection control, but just broadly speaking, because surveyors in some cases were in our buildings every week. And so this is ending. It ended as of July 31st. That will reduce their survey load also, which should help us with timeliness of annual recertifications. Now, COVID compliance, infection control compliance will be rolled into our regular survey processes, or it might potentially come to fruition somehow in a complaint survey if something is around infection control in a complaint survey. But it's part of the normal survey process now. F880 and F881 are the tags for infection control, and those do remain usable. It's just they're not going to be a specific infection control survey moving forward. And last but not least, our fall convention is rapidly approaching. We really hope to see as many of you there as possible. We love to have you as our special guests and for you to see what all of your providers are being exposed to for education and encouragement, and just be enjoying being side by side with us all. It's a great time. It'll be in Loveland again, September 16th to 18th, a little earlier this year. And we hope to see you there. It's at the Embassy Suites. Thank you so much.
Thank you, Jenny. That's a very nice picture too. Why don't we have Chad go ahead and give your updates, and if people have some questions after that, maybe we can have just a couple minutes for questions.
All right. Hello.
Hi, Chad.
I just wanted to mention, we are in the process of transitioning from the survey data and operation system from Aspen to iKeys, to throw out some acronyms to you. It's a web-based system. And, the survey process is going to be the same essentially. But, anytime there's change, we're going to have a few growing pains. And I don't believe facilities should be affected by this at all, except that we're probably moving just a little bit slower as we build more muscle memory around the process ourselves. Just to kind of make you all aware of that. As was mentioned, we have a growing number of overdue recertification surveys as a result of our work to manage the complaint and FRI workload, those facility reported incidents, and as well as our efforts to develop independence in a large number of newer staff. So we are, growing pains and more growing pains, but hopefully, that will all level itself out. So the changes to the state operations manual from April of this year really ensures increased involvement and oversight by the medical director. Medical directors should experience an increase in the number of conversations being had with surveyors. And I just want to remind everybody that really the purpose for these conversations starts with helping us to understand the facility's practices. And while you might not be aware of the day-to-day care provided to specific residents, it's also extremely helpful for you all to share your clinical and professional insight into expected care practices. So again, our conversations with you all is really built around our, we're seeking to understand. As Jenny mentioned, the infection control surveys, there's change with that. We do not have the focused infection control survey. So instead of the full review, although the full review does continue to happen with recertification surveys, we'll still look at infection control issues, but we'll look at specific concerns that are related to allegations in the complaints that we receive. And just wanted to really give a shout out. We were able to attend Dr. Eber's presentation for the OFSA conference. So that's the state organization for survey agencies. And we really enjoyed hearing all of the great information she had to share. Plus, it was nice to see a familiar and friendly face.
Thank you for representing us, Leslie. Thank you. Yeah, appreciate all the updates from the CDPHE and from CHCA. And I think tomorrow, is it, Chad, is your next nursing home stakeholders meeting reviewing the Chapter 5 regulations? I know there are.
That's correct. And we canceled today's nursing home roundtable, wanting to encourage as much attendance for the stakeholders meeting tomorrow as possible. That will be held on the CDPHE campus. So for all of those that are able to go, and if not, we sent out the link to that meeting as well, so it can be attended virtually.
Thank you for welcoming our community in that process. We've heard from several members already who want to raise some awareness of this issue or that issue. If anybody on this call wants to bring some issues forward, join the meeting or let myself or one of the other board members know so we can bring it up.
And Chad, it's my understanding tomorrow that we're going to discuss medical director role. That's part of it for tomorrow. Is that true?
I believe so. There's a number of topics that we want to get through.
Yeah.
But as kind of with everything, you can really see how the medical director influences or is involved not only with just that specific section, but with all of those sections that are a part of the state rules.
Yeah, I'm just trying to drum up business with this crowd.
So that would be a particularly key meeting to attend, you're saying, right?
It would be nice
Yeah,
to see
that would
everybody
be-
in person. 1 to 3,
Building B, right?
correct.
Good to know where you're headed. Well, thank you very much. We appreciate you. Right, well, now I have invited Doctors Eber and Gahm to address us on some clinical issues. And Dr. Eber, as you all know, is a past president of CMDA. She's also the president-elect for PALTmed. So, Dr. Eber, could you start off with the respiratory virus vaccination announcements?
Sure, thank you so much. I just wanted to say what an honor it was to go to the AFSPA conference and present there. It reminds me that we really all are on the same team, that we really all have the same goals to help patients and to advocate for patient care. So it was a wonderful experience. Today, I wanted to visit on where we are with the COVID-19 vaccine, the popular topic of the day. So on Wednesday, the FDA announced that their recommendations for the 2025-2026 COVID-19 vaccine, they are authorizing it for everybody over 65 and those who are high risk of having poor outcomes from a COVID-19 infection. And if you go to the CDC website, and we can put that link in for you as well, you will see that high risk is all the usual players. If you have COPD or asthma or chronic lung disease, chronic coronary artery disease, chronic kidney disease, cancer, diabetes, but also obesity, if you're a smoker, if you're on steroids, if you have certain mental illnesses, you're also included. And we will, the ACIP is supposed to meet next week, but this is kind of a smaller group than has usually been recommended for the COVID-19 vaccine. So I also wanted to let you know about something called the Vaccine Integrity Project. And this project is organized by CIDRA, which is out of Minnesota. And what they did about 2 weeks ago is go through all of the data out there for vaccines, COVID-19, influenza, RSV, and they had the top researchers and experts in our nation go through that. And I'm also going to share with you that link. Many groups, including the American College of Physicians, the AMA, the American Academy of Pediatrics, and PALTmed, are using that data to inform their decisions about what their medical societies are going to recommend for the COVID-19 vaccine. So if you want to see that in person, hold on, I'm going to see if I can share it with you right now. Hold on to your hat.
The CIDPHE
Oh, you
link.
did it already?
Is that what you were looking for?
Let me see. Hold on a second.
Vaccine Integrity Project.
Oh, yes. Thank you. Yes. Thank you. Thank you. So in that vein, I also wanted to update you that PALTmed will be providing a tool for nursing homes and nursing home residents, medical directors, and providers to who to give the vaccine, when, and who is authorized. We are going to build our vaccine recommendations and align them with our trusted partners, the American College of Physicians, the Infectious Disease Society of America, and the AMA. And so we are going to make sure that we're aligned with them so you don't have conflicting, you already have enough confusion with the COVID-19 vaccine. I certainly don't want us to add to it. So that is pending. We're also going to make some recommendations for staff, and then herein lies the rub. This is so important because right now some data shows that vaccination staff are about 8% of staff are updated with their COVID-19 vaccine. But here is the issue, is that most staff do not fall into one of these buckets for the FDA recommendation for the COVID-19 vaccine. So CMS still requires that facilities educate people on the COVID-19 vaccine. But even if your staff members hear your education and then would like to get the COVID-19 vaccine, many of our staff members are ineligible. And so that, of course, is ironic. Nationally, ACA has been promoting vaccinations to many communities and leading age. And, I think we're all struggling with that little bit of mixed messaging of we have to educate our staff on the COVID-19 vaccine, but can't offer it to them. One of the things I thought was really interesting is ArchCare, which is the Archdiocese. They have several nursing homes nationally. Their CMO was talking about the fact that we want to, the message we want to highlight to our staff is not that we're not like the general population. We take care of really high-risk patients. And the thought that even though things are fairly good right now, even though we're in a minor wave, we should always be prepared and protected. So that's something we want to talk about with our staff as well. Let's talk about some of the availability in Colorado of the COVID-19 vaccine. So right now, Walgreens, King Soopers, Safeway, nobody has the vaccine yet, the updated 2025-2026 COVID-19 vaccine. They all expect it to come the later part of this week. There's nationally CVS and Walgreens, this is especially for our staff, requires and Safeway, I'm sorry, will require a prescription from your provider in order to get a COVID-19 vaccine if you are under 65. So you can't just go in and say, I have diabetes, I'm part of the high-risk group, and I am 58 years old, won't you give me the COVID-19 vaccine? They will certainly say no, because you will need a prescription. King Soopers, it seems like, just needs you to attest that you are part of a high-risk group. So I talked to 2 King Soopers pharmacies this morning, and so far they're sticking with their idea. They are not the vaccine police, and that if you attest that you are part of the high-risk group, they will be giving you that COVID-19 vaccine. Remember, that group has a long list of people to include. And so that is the availability. But remember, most places will require a prescription if you're under 65. The last thing I just wanted to encourage everybody is to lead by example. I will be hoping to get my vaccine. I have 2 facilities right now that are in COVID-19 outbreaks. And yesterday afternoon, I had my first COVID resident death, which was really overwhelming. From COVID-19. And so I am very interested in not adding to my patient's risk by not being vaccinated. I don't know if anybody has any questions.
Thank you, Leslie. You always lead by example. We appreciate your comments and your advocacy. I think you answered Dr. LaRocca's question about the prescriptions.
Yeah, that is just
this information about Safeway, King Soopers, and all that. Do you want to share how you know it?
Oh, just by talking to the pharmacist, going there and talking to the pharmacist, and then making some more phone calls this morning. For a while, we thought that Safeway would go the way of King Soopers and not require a prescription, but as of this morning, that is no longer true. So everybody needs a prescription except for King Soopers at this moment. Yeah.
Leslie, do you mind if I ask, since you talked to them, this is Christine.
Sure.
I've gotten a lot of vaccines at supermarkets, and it always seemed in the past that there was a blanket physician prescription that was allowing that grocery store to give me the immunization. So when you say they need a prescription from their PCP, and how do they know it's their PCP?
Yeah, I think that's a great question. Thank you for asking that question. They need a prescription on a piece of paper or sent to the pharmacy in some way saying that Leslie Eber can get the COVID-19 vaccine, or I am prescribing the COVID-19 vaccine for Leslie Eber. It doesn't really have to be your primary care doctor, but it needs to be a prescription for you as an individual. Some of the conversations that are happening nationally, right, in the past couple of days after this happened on Wednesday, is that some medical directors are wondering if they are going to facilitate their staff members by writing individual, prescriptions for staff members if they want a COVID-19 vaccine, and they are, that is a possibility. And I've heard some folks on the East Coast where their facilities are trying to facilitate that. It's another option.
I was going to say a lot of our staff members and our providers in the community get their vaccines at the facility on the day of the vaccine clinic. Would there be anything keeping people from getting it there if the facility is willing to administer?
I think that that's really unclear right now. I think that like Norvis, there are different companies that come into the facility that I know are popular here in Colorado and the Denver metro area. They do a beautiful job. They come and they give vaccines. One of the reasons that often they do that is they do all the paperwork for the facility. They put them in SIS. They bill for the residents. They bill their insurance companies or even for staff. I know that there have been issues where they don't cover all the insurance companies. So some staff members have gone up saying, I want the COVID-19 vaccine. They said, we are happy to give it to you, but you will have to pay for it. Right now, the price of a COVID-19 vaccine I'm hearing nationally is like $149 to $175. So it's not inexpensive. It's kind of a bigger lift for some of our frontline staff. And so, I think that will be interesting. And I don't know if Norvis will be giving a vaccine to a person that does not meet the FDA recommendations. I think that's a question. I don't know what the answer is. Does anybody else know maybe if these companies will be giving vaccinations to staff members that aren't recommended for the COVID-19 vaccine? I don't know either. It's a long answer to a short question.
Thank you for highlighting that, we don't know part. And hopefully with a little time, we will get to find out some more answers.
Thanks.
Greg, we have you next. Would you like to make any comments following Leslie's and then also update us on what you're thinking these days for influenza and RSV vaccination?
I will do that, but I'm going to start by interrupting myself to welcome back one of our longest and most loyal members, and I'm going to give her the stage for a minute. Christine, welcome back. Tell us what you're doing, and congratulations. I caught her off guard, I think.
You did. And that is so awesome. Let me see. I can't seem to get my video to work, which is probably good because it might start crying. Christine Laraca, geriatric medicine physician, for those who don't know me, fellowship trained at the University of Colorado. Very proud of that. Work for Telegen, population health management company that has consistently been a quality improvement organization under contract with CMS, literally for decades. The Quality Improvement Organization program is required in the Social Security Act. There was a lapse between the last contract cycle and the current contract cycle. For those who care, it was the 12th scope of work and the 13th scope of work. I think they should have skipped the number 13 like they do in hotels, but oh well. The 12th had a pandemic, so maybe the 13th is going to be great. And but Telegen is now the Midwest Quality Innovation Network Quality Improvement Organization under contract with CMS. And never before, and people who know me know that I've been with this very valuable program since 2001. We've got more states than we've ever had. So we are covering 14 states from Missouri to Alaska. Try to explain to the people in Oregon why they are the Midwest QIO. Just help me out there. But we are hoping to do great things with this 5-year contract, and we are here to support you. What's different is that there is a service provider list that we are going to be focusing on for more targeted assistance but many nursing homes, and you know, you can always reach out, check our website, resources, reach out to me personally. I can't quite figure out the right word, but I think I was laid off. I was severed. That sounds like a foot or something. But so I was gone for about 3 months, but I'm back now and could not be more excited. And again, I'm here to support you, same email address. And we're focusing on great things in the nursing home, including somewhat new, helping with technology and interoperability. And also very, very focused on workforce issues, which I know are top of mind. So thank you so much, Greg. I appreciate that. That was off the cuff, not crying. Okay.
It was good. It's always good. Okay, so I'm going to try to share my screen so you can look at something better than me. Let's see.
That's still you.
It's still me? That's not good. Let's see.
It
It
was just
says
a picture of you for a second.
Yeah, I like it.
yours. Is it still me or is it show now?
No,
We
it's
can-
Oh,
showing.
it's still. Okay, it says I'm screen sharing. Let me just see what that says.
We can see your slides now.
Okay,
Lisa,
great.
quick
Okay,
vaccine.
so this is going to be really low key, and anybody that do the same thing I always do. Anybody that wants to interrupt me at any time, just come off mute, say your piece, and we'll take it from there. And I don't know how far we'll get, but we'll enjoy doing it while we can. Okay, so first thing we're going to do is start. Let's see if I can do this. There we go. We're going to start with vaccines. A couple comments. Flu vaccine probably available starting this month. I haven't heard anything specific. There may be some folks already receiving them, but I haven't seen any yet. This year's vaccine is trivalent. They gave up the second B vaccine last year because it had disappeared. Vaccine was so effective that nobody was getting it. So now we're just back to an H1N1 and H3N2. This is the one that affects our patients the most. And a B Victoria, which is really here year round in small numbers. But nonetheless, trivalent vaccine. When do you vaccinate? When you get the vaccine. If you have staff and relatively healthy persons under age 65, anytime after you get the vaccine is a fine time to go ahead and vaccinate. For sicker persons, comorbidities, people over 65, I break away a little bit from CDC recommendations because we have a captive audience and recommend vaccinating closer to Thanksgiving or somewhere shortly thereafter in December, unless we have an early outbreak, which we do on occasion, in which case we'll try to get the word out. But if we don't, then somewhere end of November, first half of December is great. The reason for that is if you vaccinate now, in seniors, the immunity wanes off after about 90 days. It just starts disappearing. In 90 days from now will be before we hit the peak of flu season. So the vaccine won't be nearly as effective as it should be. Which vaccine do you use? This has gotten really easy. It's the same thing every year now for a number of years. Anybody over 65 or people that are especially sick should get either the high dose or the adjuvant vaccine. Doesn't matter which one, different companies, a little bit different vaccines. They're both equally effective and much more effective than a standard dose vaccine in this population. Everybody else, standard trivalent vaccine is just fine. So that's it on flu. Couple comments here. This one's going to be really simple. Pneumococcal vaccine. Prevnar 20 is about 52% effective against the pneumococcal subtypes that are circulating. Prevnar 21, Capvaxive, which has been around for about 2 years now, is 84 to 88% effective against the pneumococcal subtypes that are circulating. And given that information, I don't have anything important to say other than you figure out which one you should be using. I get terribly irritated when I see Prevnar 20 being given still. I mean, it's not twice as effective, but pretty close. And if you give Prevnar 20, you're going to have to wait an entire year to give 21. Give the vaccine that works. Couple other vaccine reminders. There really is no more effective, safer means, and this goes for COVID too, to be protected from these viruses than to stay up to date with vaccinations. So regardless of what the press or other people might want you to believe, if you just look at the data, it's black and white. It's not even difficult to figure out. Remember to remind your facilities when you get your vaccine, get it to the vaccine refrigerator quickly when you receive it. It only takes about 4 to 5 minutes at room temperature to render most vaccines inert. 4 to 5 minutes. And the reason that's important is when you give vaccines, remember the same thing is true. So if you take them, you've been doing a great job keeping them in the vaccine fridge, and then you take it out for an entire wing to go vaccinate people, and you're out there for 45 minutes, and most of the vaccine you gave didn't work. Okay, any questions on any of the vaccine information before we move on? Okay. If you do, just cut me off.
Dr. Gahm,
Yeah.
how do you approach a facility where the administration is convinced that it is not financially lucrative for them to offer vaccines, or they're politically not convinced about vaccines?
Well, they're going to do it for patients because it's going to get paid for. Staff, yeah, that's a bigger issue. It's a lot of facilities don't want to pay for vaccine for their staff. They want to draw on their insurance. They're not all insured. So they'll do a lot of that. They'll provide it for people that can provide insurance information. I don't know. I mean, that's a philosophical question. In the big picture, the easiest way to bring a respiratory virus into the facility and make a whole bunch of people sick and move them out to the hospital where you have empty beds sitting around you're not getting paid for, is to let staff not be vaccinated. So I think it's, to some extent, it's short-sighted, but it may be a financial
I find myself not having any room to maneuver when I'm not able to convince them.
Yeah, well, they're always welcome to get in touch with me. I'll be glad to just share information with them and, ask them what it costs to have, if they only had 3 patients get influenza and end up in the hospital for 5 days each, what is the reimbursement for 5 days of not getting paid for 5 days on 3 patients? So what's the cost? 50 per diem days.
And Dr. Reddy, has your approach been to talk to the administrator or the DON or do some presentations? I'm wondering what strategies you've tried already.
I've spoken to the medical director, and both of us have spoken frankly to each other. And the medical director has had these meetings with the facility. And I mean, both of us have basically been able to see that the administration has been mostly financially motivated and just realized that the administration has changed and that their approach has mostly just been, it's just not financially lucrative, like it's too expensive. And we don't know where to go from there.
Yeah. It's short-sighted.
Yeah.
Okay, moving right along. We're going to start out today with a philosopher that I heard a number of years ago. Said lifetime learning is a never-ending process, and it is difficult. And he immediately followed that up by saying lifetime unlearning is even harder. And some of you, I know Christine knows this person, Those of you that were lucky enough to be around here long enough remember Robert Schreier from being chief of medicine at the university here for a long time. And this was part of what he shared with us at our graduation. And told us at the time that 50% of what we learned in medical school would either be obsolete or wrong within 10 years, which is a really difficult thing to believe at the time, because you think you're getting high quality education, and then and all the time you spent learning it, to think that half of it would be wrong within 10 years was really a problem. Nonetheless, that's what he said. And so today we're going to focus a little bit on both of these things. And actually, we're going to start with a little bit of the unlearning. In my career, the major things that I've had to unlearn have been things like postmenopausal estrogen, antiarrhythmics for people with PVCs and cardiac arrhythmias. Lately, it's been things like aspirin. So anyway, let's talk about this. So UTIs, we have had, I don't know, in 10 years, probably at annual meetings, 6 different lectures on what is a UTI and what not to treat. I've probably given 200 of these lectures, and I still, even in my facilities, see one after another person getting UAs because the patient had altered mental status, falls, confusion, all kinds of odd things. They get a UA, shows 100,000 bacteria. They're not febrile. They don't have a high white count. They don't have a left shift. They don't have any urinary tract symptoms. They don't meet lobe criteria. But now you got 100,000 bacteria, and 99 out of 100 people feel compelled to treat with antibiotics, and not for 3 days, like what's recommended, but for a week or for 10 days. And what they've really got is asymptomatic bacteriuria that you treat with water. This is one of the things to unlearn what all the myths you learned about what a UTI is, and go read the data. Neurontin, we had a wonderful presentation a couple months ago. And I did this a little bit in Journal Club on part 1, but just in the past month, since I gave that presentation, there's a new article that came out actually, now it should say last week. And this was the title of the article: Are gabapentinoids effective at reducing pain, improving sleep after nerve injury? There's the reference. Here was what they figured out. Gabapentinoids did not reduce pain compared with placebo at 1 month or from 2 to 4 months after treatment. And they didn't really help with sleep. Their conclusion in the article was best available evidence, which now consists of 4 large randomized controlled trials, suggests gabapentinoids should not be used to reduce pain intensity or sleep disruption in people with peripheral nerve injury, given their substantial side effects, potential for misuse. And I'll tell you, the education is right here. The unlearning is, I've been doing this for so long, and so many people don't believe it. They must be right, not the information. I'm just throwing it out there. So here's the other one that is another one of my pet peeves. We talked about this a month ago at Journal Club. Depakote doesn't work for behaviors associated with dementia. Up to date corroborates that. I don't have to read it to you. Depakote does accelerate brain atrophy, has many serious, often unrecognized adverse effects, increases ammonia in a significant portion of people treated with it, leading to encephalopathy, decreased platelet counts, hyponatremia, and associated problems. It isn't approved or effective for schizophrenia, but it gets ordered for it. It treats only 2 of the 10 types of seizures, but it still gets ordered because it's a seizure med. I normally see 4 or 5 cases a year of encephalopathy with increased ammonia related to Depakote. And I'll bet that I've seen 7 or 8 in the past 2 months. I don't know why, just bad luck maybe. But that encephalopathy, part of the problem, a lot of these patients are bipolar. They have psychiatric issues, and a lot of the things that you see, a lot of the clinical clues look a whole lot like bipolar, so you just keep piling it on without thinking about encephalopathy. So what does encephalopathy look like? Well, erratic sleep patterns, excess sleep for a day or two, and then up and down, not sleeping at all for several days. Impaired attention, cognitive difficulties, hallucinations, hypervigilance, rambling conversation, and new seizures. A lot of this looks a whole lot like bipolar, so it's easy to miss it. Check a lab. If you see an elevated ammonia level, the treatment is not, well, let's pare it back a little bit, see what happens. This is a person whose liver does not work well with Depakote. Get rid of it. You got to get rid of it to get rid of the encephalopathy. And what you'll find is that clinical improvement parallels the decreasing ammonia level. Again, another thing to learn. All right, let's move on. Benzodiazepines, how long? I mean, in the 1970s, we started using Valium for anxiety. It's 50 years later. We've improved. Benzodiazepines are not very effective. The American Psychiatric Association places them as a distant class of drugs to choose for treating anxiety. Not more effective than seizure meds. Addiction, sedation, falls, obviously, are among their many adverse effects. Might be temporarily useful if you start the appropriate anxiety meds. So what are they? SSRIs, drug of choice, 60 to 70% efficacious. Placebo was 40%, tells you something about the issue. SNRIs, interesting, they're listed a second, but they're essentially identical in trials. And this is, think of them more like you would a non-steroidal. Somebody doesn't work well with Aleve, and you give them Advil and they get a response. Same idea here. Lack of response to Zoloft doesn't mean that Paxil won't work. So switch, feel free. Problem is it takes 6 to 8 weeks to get to steady state and get to an effect, stable effect. So it's a slow process. After those, Buspar, after that, other antidepressants. And then finally, in the much less effective category, benzodiazepines and seizure meds. And with the APA, when they wrote their white paper, there's a huge gap here between 4 and 5. Okay, so leaving anxiety behind, and I'm just going to keep moving along for another 4 or 5 minutes and we'll stop for questions. Insulin and type 2 diabetics, boy, we have so many other better choices these days. Type 2 diabetics, insulin resistance and obesity are the problem. And the more insulin we give, the more we make that problem worse. This doesn't really fit, this part of the advice doesn't fit well with our nursing home patients. Lose weight, get up and exercise more. Yeah, good luck. Sliding scale insulin, clear back 2009. So where are we, 16 years later? Tight controlled insulin in type 2 diabetics more likely to lead to hypoglycemia with syncope and falls and a decrease in end organ damage or mortality. This is what we're trying to do. We don't want them to get as sick and we don't want them to die. Sliding scale insulin is not the way to get there. Up to date, I just did this a couple nights ago. Treatment regimens should be chosen with focus on avoiding hypoglycemia and control real hyperglycemia problems. So for up to date tells you in folks requiring insulin, metformin with a once a day basal insulin is effective, relatively simple. Sliding scale should be avoided except when you're changing medications and you need to see the effect, or acute change of a condition like infections where you may see a big bump. And then one last plea, let's join this century and quit using regular NPH and 70-30. The problem we had, those of us old enough to have used these as the only thing we had, is you were never quite sure when they were going to kick in, how long they were going to last, was there going to be overlap? We don't have that problem anymore, but we keep using these drugs anyway. Let's go to this one. Cholinesterase inhibitors, memantine. Okay. Hang on just a second. There we go. Side effects, much more common and significant than any potential possible clinical benefit. Common side effects of these listed here. And if you look, I mean, this is our population. This is where they live. We don't want to be adding drugs that lead to that. And then one of my favorite geropsychiatrists leaves us with this quote: by the time patients reach long-term care, they're way beyond these medications being helpful. Hopefully a lot of you remember Leah Watson, and she's still active with us, but you know, they're just not a good choice. Families sometimes want to hang on to them, and it's their last great hope. Talk to them, ask them what they expect out of it, and then let them know if that's realistic or not realistic. I have more slides, but let's stop here for now and see if there are any questions or input from the audience. Anybody?
We appreciate you.
By the way, feel
Oh.
free to disagree.
No,
Go ahead,
thank you
Sam,
for
sorry.
doing this. I know you had started this presentation during one of our journal clubs, so thanks for taking the next phase of it here to this meeting. Any questions from people? I have a question. What are you seeing and recommending right now for frequency of finger sticks when people are on either insulin or some of the newer diabetic medications?
Yeah, I think, you know, checking them frequently for a couple weeks until they get to steady state and they, you know, figure out what it's going to do with their particular appetite, probably a fine idea. But what I really get irritated by is, you know, BID, TID, finger sticks every single day, you know, and then we're giving 2, 3, 4 units of rapid insulin. You know, we're not stopping end organ damage. We are not preventing severe hyperglycemia, but we're using patients like pincushions. Just, you know, if you get basal insulin with it, 7, 8, 9, 10 sticks a day is not much fun. You got dementia coming at me with a needle 10 times a day. It just, and really no chance for clinical benefit. We can do better. For people that are unsure, uneasy about it, check it twice a day, twice a week for a while, and then maybe twice a day, once a week. And then whenever they're symptomatic. We don't use that information very often. Does that answer your question, Sue?
Yeah, I appreciate that. You know, there should be some parameters on how we use it. Dr. Durgan's commented in the chat box while you're talking about that too, is that she's seeing a big increase in the number of patients coming into skilled from either the hospital or the PCP and endocrinologist with sliding scale orders, and they get upset when it's discontinued. Any thoughts on why we might be seeing more sliding scales from certain patients?
Yeah, I'm gonna stop sharing here. Yeah, we see a lot of that, and nobody wants to, you know, argue with the specialist. I do. You know, I argue with the specialist because it's my patient, not theirs, once they get to the nursing home. And my goal is patient comfort, you know, decrease morbidity, mortality. And, you know, I usually, whether it's amiodarone for atrial fib or frequent finger stick blood sugars, I ask the specialist if they have any literature to support what they're doing. It might be aspirin after a hip fracture. You know, where's your evidence? Because I know where mine is. Yeah. I don't know. I mean, that's a difficult, it is hard to take a stand, but one of the things I would convince, especially this group, is you guys are specialists. You're geriatric specialists. And the endocrinologist that's treating diabetes in his office isn't focused on geriatrics. You are. Treat your patient. You're the one that's writing those orders and you're in charge. I don't go in the hospital and write orders and they wouldn't let me, which is good. But, you know, having them decide that they're going to tell me what to order at my facilities, not necessary.
And thank you, Dr. Weber, mentioning, well, how is this similar or different in type 1 diabetes patients? Same.
Oh, real different. Different disease. Yeah, type 1 diabetics, yeah, you know, use that freestyle and the insulin pump and stay on top of it. It's a different disease and it makes a difference there.
Now I'll ask you the same question I asked Dr. Reddy. I mean, we do bring this education to our partners and to our communities often, whether it's UTIs or vaccination or sliding scale. And sometimes, you know, things just don't change. What have you found to be effective when just educating people doesn't change the behaviors?
I'll open that up to the crowd. You know, in my most effective days, I just tell people we don't allow it. Things like lidocaine patches after the FDA letter came out saying they don't work and insurers don't have to pay for it. That's an easy one, you know, so we just don't allow them. The other stuff, I don't know. I mean, it is part of what Schreier was saying is lifetime education is difficult and unlearning is even more difficult. Boy, if you're not willing to be educated, or one of my pet peeves is people will get it right in my facility because they know that I'm hawking a particular thing and they won't do it there. And then I'll find out that they're doing it in other facilities, which to me is patronizing, and it shows that they missed out on what the education meant. I don't know anything that works. Anybody? We got a
Very
lot of
challenging.
expertise on this call.
We do. Yeah. I was wondering, Dr. Eber, if you have any thoughts? You just
For folks not kind of consistent in their implementation of best practices, or I'm not sure, is that the question?
right? How do we, you know, we do get frustrated when we feel like we're giving the same education again and again, and it might be UTIs, it might be vaccines, might be sliding scale. What have you found that might be more effective than just giving the education again?
You know, I think that I like the ideas of behavioral modification, behavioral change science, so that whether it is, I've done this at one of my facilities, kind of having different doctor groups and we compare. How are you doing for ordering UTIs that don't meet criteria? And then we share that information with the doctor groups, and then often that promotes some competition of being more prescriptive about not ordering the UA. So I think that comparison can kind of kick people in, you know, to higher gear of being really consistent. Those nudges to make sure that before you order a UA, some of my facilities have the nursing managers have to approve every UA that's being ordered. And so often they just say no. And they said, if you'd like to talk to Dr. Eber, we're happy to share her phone number, of course. And so some of those nudges, I think, often can also make a difference.
Anyone else?
I will say, saying that, you know, we all went into this field, wake up every day trying to do the best we can. But I agree with Greg that the toughest thing is firmly held misinformation. And if people can see that, you know, as Leslie said, that patients are going to be safe and that the outcomes are going to be equal. If I don't do X, Y, and Z or prescribe X, Y, and Z, I think that helps to build their own evidence base. And we're all kind of, it goes with this field as well, that we're all a bit competitive. So I applaud you, Leslie, for, but people want to feel like if, you know, it maybe they have a mentality of if it's not broke, don't fix it. But it might be broke and we're not really seeing it, like Greg was saying, that we're attributing symptoms to maybe bipolar when it's actually the drug. So, but confidently held misinformation, I got to tell you, that's the toughest.
Yeah.
Thank you so much. We appreciate your insights. Thanks everyone for joining today's meeting. We look forward to seeing you on our journal club this Thursday. Take care.